The challenge was, in essence, to attempt to synthesize a bit of everything that has been said while also attempting to see how we can summarize long COVID, because it is truly a real question today. We saw this with all the speakers in the context of their discussions. There are many causes, there are many symptoms. We cannot talk about long COVID. We should talk about long COVID cases. And above all, what is extraordinary, if you look closely, is that there are several ways to manage it and that everyone has good results. Dominique uses nosodies, isotherapies, and therefore works on blockages, etc., with purely electromagnetic messages of a homeopathic type. Pascal demonstrated a very comprehensive approach, but also based on homeopathic immunomodulation, of course, along with nutrients. Claire demonstrated, even if we weren't specifically talking about long COVID, a care approach that I would describe as holistic and integrative, somewhat like what Michelle just did. And the results are indeed simply neither better nor worse for one than for the other. This also means that depending on your habits and sensitivity, whether you are homeopathic or not, there are always things you can do to help patients, much more than doing nothing, as is often done today, or considering that it is all in their heads. So what is long COVID actually? Is it the persistence of symptoms from acute COVID? I will say things that are a little bit different from Pascal, but at the same time very complementary. This is my perspective on the matter. Reasoning. That's how you will find it again. I will go quickly, because you will find it in the review that I had written on the subject, which I distributed to you. Are these persistent symptoms? That is to say, you have symptoms and then they remain, like anosmia, for example, nothing else happens but a scar. Is it the secondary and persistent appearance of other complication symptoms? Is it a reactivation, an aggravation of a fragility, a chronic infection, or an autoimmune disease, for example, as we have seen? And then, what is long COVID in terms of time? Several have said 6 weeks, 2 months. Pascal said it very well. The symptoms right away, and then a little later. And then today, we see long COVID cases lasting 12 to 18 months. So these are definitely not the same patients. This has been stated very clearly. So I will go quickly, because these are practically the same studies that Pascal showed. We should have roughly the same figures, but we will see that they are, I would say, variable, depending on what we consider. So here, for example, I took the example of a Danish study that shows that 1, 2, 3, half of the people with severe cases of long COVID did not show improvement after a year and a half. And indeed, it is very clear. Claude has also shown that people who are not treated have much more severe cases, and if they have more severe cases, they experience more long COVID. So here, we are talking about a year and a half. You see? We are starting to really deal with very, very persistent symptoms that we will need to understand. Studies suggest that long COVID cases became less common as the pandemic progressed. This is thanks to vaccination. Or it could be because the variant has mutated. But that is also the problem. It's the interpretation we make of all this. Because really, I was jokingly saying that, in part, the conclusion is that there is less long COVID since we started vaccinating. No, there is less long COVID since the virus has mutated and the COVID cases are less severe, as long COVID is specifically linked to the severity of COVID. And here it is, of course, the hypocrisy of the interpretation that deserves a bit more study. I obviously refer you to all the videos we make at the CSI where we try to demonstrate all of this. So here, for the CDC, in the United States, 15% of American adults have suffered from long COVID, and about 5% report currently suffering from it. This is a relatively recent study. I have included the relevant and detailed sources in the slide that you will find, and comprehensive. For others, therefore, it's 15%. But once again, it depends on what we are talking about. Because here, we were only discussing cognitive disorders. And of course, cognitive symptoms have decreased since the vaccination. However, since the vaccination, the variant has completely changed. Or perhaps cognitive issues are less significant when people are vaccinated because they are less afraid of experiencing severe COVID. There are many biases in these studies, and I will come back to this because I remain convinced that some of the people with long COVID actually have post-traumatic stress syndrome. As you all know, especially in the first year, people who had severe COVID and had no medical support stayed at home with Doliprane. praying not to worsen, not to end up like the man they saw on TV, lying on his stomach and intubated, because that is what they were shown in phase 2. So imagine for people who are not well acquainted with medicine, how distressing it could be. I know that I have a friend who got vaccinated just for that, because he saw on TV people intubated, lying on their stomachs saying, I don't want to end up like that. I told him, but don't worry, I have 0 patients who ended up like that. I have 0 patients in intensive care out of more than 1,000 sick. At that time, I hadn't had 1,000. So I think there are many psychological factors. 31% of people who developed long COVID reported initially having very severe symptoms. So you see that there is a link there, is 14%, but 31% when they had severe COVID, we still have the same figures. In France, this is part of what I believe Pascal has also shown, so I will be quick. Thus, post-COVID infection is estimated at 4% in the general population and 30% among infected individuals, totaling 2 million people age 18. This prevalence decreases with the time elapsed since the last infection. Well, there you go. So it's always the same figures, whether in the United States, etc. And Pascal showed a meta-analysis, I believe, on this. There are more cases among women, more among the working population. Well, there you go. And obviously, there are more cases when they have been hospitalized since they had a more severe case of COVID. So this is very interesting because we were told that we need to vaccinate the elderly because they are at greater risk of developing severe COVID. But in any case, here, in long COVID, it is not severe COVID, of course. Age has not been identified as a factor. Well, so what are we talking about? Because obviously you understand that all these studies mix everything up. It is our leaders, our health agencies that use these figures, while we haven't even defined what long COVID is. We mix pears, plums, and apples, and we try to see a little bit of what we can understand from it, but no. I will try to summarize the main causes for me. So this is really my position based on what I have been able to observe, study, and my experience. The main causes of long COVID can be a persistence of the virus. I know that some of you here are really treating long COVID like this, especially at the beginning. It is believed that the virus does not disappear after a few days. It is present and persists. This could be the awakening of a crypto-infection. It has been widely discussed, and in my opinion, it is one of the main causes of long COVID, truly long. Obviously, this COVID is due to the spike protein, because here, in fact, we will clearly understand that we will summarize all of this under the name of spikeopathy. I didn't use it in the slideshow, but it is really the spike protein that is involved, whether it is from the virus or from the vaccine. I intentionally did not talk about the vaccine. You saw that in the program. I never mentioned it because talking about the vaccine leads us to political, philosophical considerations. I don't know what, and that's not very interesting today. In my opinion, the vaccine deserves at least a day of recognition like this, and then it can leave a scar. I spoke earlier about anosmia, a symptom of acute COVID, and among the symptoms that can persist from acute COVID, there is this fear, this anxiety, the psychological trauma, that must not be overlooked. And there are patients, in my opinion, whose main treatment will be psychotherapy, particularly EMDR. So in the case of virus persistence, what do we do? First, is it common? I have no idea about that. It hasn't been studied because there isn't really any possible examination. I think that especially in the first months, when we have a COVID that lasts, we should actually call it persistent COVID rather than long COVID, because we are not yet dealing with the long COVID that we see today. And so, in my opinion, the persistence of the virus when it comes to long COVID lasting more than a year, I am not sure it is the cause, but in fact, I don't know. I don't know because there is no routine diagnostic possible. We can perform spheroid studies, as we have seen, and maybe if we measured the anti-N antibodies, because she mentioned them, nucleocapsids, which are specific to the infection, and the anti-S antibodies that are mixed, related both to the infection and to the vaccines. We might have a small idea, but as many people are vaccinated, the more they are vaccinated, the more they get COVID. No, I find, contrary to what is said on TV, that they have more severe COVID cases. So I sincerely believe that vaccinated individuals cause more problems. And it's normal, since COVID comes. It is as if it impacts your immune system because of the spike protein. And the vaccine impacts it once again. So necessarily, since the COVID disease is an illness related to the immune system, it is not the virus. No one died from COVID. Everyone died from the immune reaction to COVID. If you keep re-stimulating with the vaccine, with COVID, it inevitably causes problems. Thank you. So it is necessary to differentiate between vaccinated and unvaccinated patients, and that is a real problem. One thing is certain, several times colleagues have asked me, yes, but if we do a serology test and the antibodies are very high, is it proof that the spike protein is persistent, or that particularly for vaccines the virus is persistent? For me, no. The best example is when you have patients who have been vaccinated sometimes only once with the hepatitis B vaccine. They have antibodies that rise very, very, very high, and these antibodies remain very, very, very high for years, sometimes 10, 20, or even 30 years. So a single contact can produce very high antibodies. So having very high antibodies, in my opinion, is not a very specific criterion. Can therapeutic tests help us? Probably, and that's why some are giving doses of ivermectin in particular, and azithromycin again. But while it is certainly useful when dealing with persistent COVID after a few weeks, a few months, after a year and a half, I am not sure it is as useful then. That's it. So it is certain that when we have patients consulting a year later, after a certain therapeutic wandering, it becomes increasingly complex if it is a persistence of the virus. In any case, I wanted to try to give you a summary of the different avenues for the various situations. So, the treatment will necessarily be probabilistic, since we have seen that we do not have the ability to provide proof of the persistence of the virus. Today, I certainly believe that we should give ivermectin. So, we can discuss it with Claude, but I really feel that ivermectin doesn't help much, a bit. Hydroxychloroquine was also helpful, so it's true that we had less opportunity to experiment with it since there was a ban at one point, and when ivermectin came along, we all started prescribing ivermectin more. But in any case, we have people who have been treated only with ivermectin with interesting results. There you go, hydroxychloroquine, no retort, azithromycin, probably in a course. So for me, what I have learned to do in chronic Lyme disease and in crypto infections is to carry out treatments that are more sequential. It may also be because I am a homeopath and I don't like very long antibiotic treatments. But I know that Christian in particular has had excellent results with much longer treatments. I'm not just talking about COVID, I'm talking about crypto infections, so there isn't just one way to do it. But in any case, yes, I believe that we must absolutely add azithromycin to ivermectin if we have persistent COVID, with the idea that it is a persistence of the virus. And it is certainly also the best way to conduct a therapeutic test. What are the other avenues? Obviously, zinc, we just talked about it. Vitamin D, we just discussed it earlier regarding Dedregil. I don't have a stake, but you know that it's a pre-activated vitamin D, and that in acute cases, it's better to use the high-dose natural vitamin D. We saw the slides. I believe it was clear, particularly that they were administering doses. No one noticed, but it was doses of up to 6 drops of 2,000, which is 12,000 units per day. We can do that too. Probiotics, without a doubt, Michelle just talked about it extensively. I will manage. Probably quercetin combined with vitamin C seems to be a really interesting anti-infective, an interesting antiviral that can be alternated with antibiotics if one does not want to undergo long courses of antibiotics. Just like ivermectin, it's very nice, but when you prescribe ivermectin for more than 5 or 6 days, pharmacists really come down on you. Already 5 days outside the approved guidelines is not always straightforward. So if you want to do 3 weeks of ivermectin, as we would like to in certain cases, I will come back to that. You almost have to buy ivermectin online from abroad because otherwise you get burned. So there you go. Or it's not even delivered by the pharmacist who calls you when he doesn't send the prescription to our friends at the order. Probably enzyme therapy, but there is also a lot of ambiguity there. I will come back to this several times because enzyme therapy is very interesting. Several people have talked about it. The problem is that there are trends and there are no really clear studies. Is nattokinase really better? Is it really going to degrade the spike protein better? Honestly, I don't know. I'm not sure. After that, we also need to find good sources of nattokinase. Is there a correct dosage of nattokinase? I don't know. We've seen several speakers talk about serrapeptase and I believe also about bromelain. Let's say we have a better understanding of the doses in bromelain and serrapeptase. Maybe serrapeptase is superior, but to bromelain, but there you go. You will have to make your own experience. I don't have any scientific argument to tell you that one is really better. Glutathione or ANAC, as Michel just mentioned, I really have a preference for ANAC. The only problem with ANAC is that if one is very old, they produce glutathione very poorly, so ANAC becomes much less effective. That being said, the ANAC is not only the precursor of glutathione, it has other interesting properties. And I always start with a guideline if I can. At what dose? Michel just mentioned it. Certainly more than 600 milligrams when there are viral persistences, even in acute COVID cases, and certainly closer to 900 to 1200 milligrams. There is 100 to 1200 milligrams. Almost no side effects. The other one is a sulfur product, so it can cause digestive issues. The other point is that it is much cheaper than glutathione. And Michel noted very well that unfortunately, the problem with glutathione is its bioavailability and its passage through the stomach, among other things. And it is also a very unstable molecule since it oxidizes very quickly. As for homeopathy, I won't go into detail here since I have made a slide. Aromatherapy, probably. Here, we return to what Claire says, knowing that I also like to alternate aromatherapy with antibiotics. It helps to avoid giving too many antibiotics for too long. And we talked about antihistamines, but we will discuss them a bit later for other reasons. The ADNH for fatigue, Michel mentioned it a bit quickly. The downside of the ADNH is that it is somewhat expensive, but it is a product that can be very interesting. And a few others. Of course, I won't go back over everything that has been said. And the dietary corrections, I put a question mark. I really wonder why, but I will come back to it. I put a question mark because I am not sure that in viral persistence, it is the essential element. That being said, eating any old way is obviously a very bad idea, and it's better to have a Mediterranean diet if you want to do better. But I will come back to this in another slide. So, regarding homeopathy, I have prepared a slide, and I will go relatively quickly. You know that for some of you, we have a discussion forum called Santé France, and for homeopaths, HomeoSense. If you are interested, just send me an email. If you want, you can join in. We have exchanged a lot about the homeopathic treatments that could interest us in acute infection and in long COVID in case of virus persistence. So, I will really go quickly. You will have the slides anyway. It's because we could debate these slides for just an hour. So, isotherapy, we talked about it with Dominique, the coral strain. I will tell you later, outside of my presentation, possibly how to obtain it, or otherwise you can send me an email. So, there are several ways to do it. Earlier, Dominique suggested a dosage of 200, 1,000, 10,000 for the treatments. We also have options when we want to go, I would say, more gently because patients sometimes react strongly. We can have this dosage of 5 granules every Sunday in 200 cases, then the same for 1,000 cases, and then the same for 10,000. Here too, everyone has their own habits. If the patient is vaccinated, we can use the isotherapy of the vaccine. The microimmunotherapy that Pascal mentioned, in my opinion, particularly MIREG, and possibly the EID formula, which stands for state of immunodeficiency. If the virus persists, you might think that the immune system has immunodeficiency. This is if no immune assessment is conducted. The best way to perform microimmunology is to carry out lymphocyte typing. We have a remedy that we have identified, which is Portia fimbriata 7CH. Some who know it well are here. Honestly, it is quite effective, and so is suramin D6 in granules. Some will use beta interferon alone, so it is immunotherapy, it is microimmunotherapy, but with specific cytokines there to slow it down. And we also have some homeopathic remedies, califosin D6, which can be interesting for fatigue, cryptolepis in basic dilution, stannum, physalis physalia in 30CH, and acid sarcolactic for pain. You can take the photo. In any case, you will have the slides. I am not going to go into the details of this treatment. And obviously, if you are a homeopath, there are symptom remedies and especially constitutional remedies. So it could also be the awakening of a crypto infection. So we all put Christian's book down. 5 minutes left. Oh, damn, this is going to be tough. Well then, I won't go into details except regarding the treatments for the summary. It is surely much more common than we think. Have you seen this pneumonia mycoplasma epidemic currently? If there is no link to vaccination, I really wonder where it comes from. So obviously there may be links to COVID and the vaccine. Viral reactivation is certainly one of the things we see most often, in my opinion, but it is far from being the only one. There's been extensive discussion about EBV, Epstein-Barr virus, as well as shingles, herpes, and CMV, cytomegalovirus. Obviously, my impression is that the reactivation of Borrelia, Bartonella, and Babesia is less frequent than that of EBV, Epstein-Barr virus. In fact, as Pascal mentioned, it has been published, which shows just how common it really is. Well, now obviously very few people are interested in these germs, and I think that in long COVID no one has looked for them, so we will have to see a bit, but my impression is that it is less common. There are candidoses that are very significant, which are triggered by a weakened immune system due to the antibiotics that people receive because it is believed they have superinfections. Moreover, as mentioned, it is often amoxicillin, which does not help the situation. Well, obviously for that, it is necessary to conduct an immune assessment and appropriate serologies. This is what we discussed with several speakers. I love discovering this article from COVAS. You know, COVAS is the scientific committee that replaced the scientific committee. And in its opinion, COVAS expresses its belief that the issue of post-COVID syndrome should be addressed under the more general term of post-infectious syndromes, which can occur following an infection by various microorganisms. So, I will let you read, but you can see that all the causes of post-infectious syndrome, the EBV, Epstein-Barr virus, SARS, severe acute respiratory syndrome, and of course Lyme disease, indicate that COVAS explains we are right. And yet, most scientists say it doesn't exist. I would like to know who does. So, you can still rely on the opinion of COVAS to tell me, in a long COVID case, I am treating reactivations of crypto-infections or whatever you want. And still in the article, the symptoms of post-infectious syndrome include, of course, fatigue, as well as a range of symptoms that have been extensively described in previous presentations, such as brain fog, sweating, and so on, which may also suggest babesia, which can indicate many things. I have provided the reference. You will have it. It's from November 7th. It's not old. I was really happy to find that one. The management of crypto-infection in this case is such that while we do not have the capacity to diagnose the persistence of the virus, we do have the ability to make a certain diagnosis regarding crypto-infections. Of course, we don't have everything we need, we don't have all the perfect analyses, but we still have a lot of elements to guide us. And if we don't have enough biology, we can test by pulse, we can test with kinesiology, however you like. So, in any case, I will be quick about this, but it's to remind that, of course, antibiotics are particularly important, and Claude in particular emphasized the importance of using macrolides or cyclanes instead. Ivermectin in EBV, Epstein-Barr virus, seems to be a really important avenue, except that it would need to be done for several weeks. And this poses a nearly medico-legal problem for us, perhaps hydroxychloroquine. I mentioned it in the case of Borrelia because to tell you my story in 3 seconds, why I got involved in this adventure. It's because when COVID arrived very quickly, Professor Raoul mentioned the treatment based on studies from China, etc., azithromycin and hydroxychloroquine. And this is the treatment we have been using at ChroniMed for over 10 years. So I knew that this treatment was effective against crypto-infections. I knew it was safe and easy to use. And all of a sudden, we are told, no, it doesn't work. We absolutely must not do that. And then afterwards, we are prohibited from doing it. So just imagine something that we had been using for years. Hydroxychloroquine was also available over the counter until the end of 2019. Yes, that's right. So that's when you start to think they take us for fools. So aromatherapy, as Claire described, seems particularly interesting, especially if there are viruses, because we do not have anti-infectives against viruses, unlike antibiotics for bacteria, even though azithromycin also works in a certain way. So you know all that. In the context of anti-infectives, we haven't mentioned propolis and black seed much. I think these are really very important avenues. I am a big fan of propolis, which is a very powerful natural antibiotic. That said, the aroma may be even more powerful, except that the aroma is a bit less easy to use. There are side effects, there are contraindications, etc. Whereas with propolis, we can say that it can be used by practically everyone. Artemisia has been mentioned, and I really think it should be considered, along with mugwort and then microimmunotherapy, especially for viruses. Several of us have pointed this out, including 2L EBV, CMV, cytomegalovirus, shingles, and I particularly noted 2L-XFS. For our colleagues who asked the question, since Pascal didn't have time to discuss it, post-viral fatigue syndrome often responds very well to 2L-XFS if the immune system is more in a state of hyperactivity rather than immunosuppression. It is true that we often use 2L-EBV as well. And so, everyone has their own recipes. Pascal will be able to say a word about it later. But I often use 2L-EBV Epstein-Barr virus first for 2 months and then 2L-XFS. But chronic EBV, Epstein-Barr virus infections are well treated this way. The same goes for CMV, cytomegalovirus. Trifluquants, 6 candidoses. Personally, I prescribe trifluquants quite often, even though I love aromatherapy and everything we can use as natural treatments for candidoses, but it usually works much faster at the beginning, and it's also a good therapeutic test. Of course, we can address the underlying condition. Of course, we will do what Michel just told us. Vitamin D especially. Vitamin C, probably. Zinc at that point. Maintenance dose, not the high doses for acute COVID. Probiotics or symbiotics. Symbiotics, I remind you, is the combination of probiotics and prebiotics. Personally, I am a strong prescriber of chlorophyll in combination or alternation. Why? Because chlorophyll acts on the fungal flora. In addition to absorbing gases, it will regulate transit and will be very, very interesting for intestinal comfort. So that's my experience. I have been doing this for over 20 years. I alternate between symbiotics and chlorophyll, and it gives me excellent results. Echinacea, well, you're right, it's not the most powerful, but it is still a good immune stimulant. Maytake, there are particularly good cakes. Claire mentioned others like endography, for example. Then there's acélangenine, which no one has talked about until now, and it's one of the African plants from Tuberie. We know quite a bit about them here in Toulouse. Acélangenine is truly the plant or plant extract that helps to act on excess immunity while also addressing issues related to fibrosis. This is timely because in long COVID, fibrosis and excess immunity are often what we aim to treat. So I will let you take an interest in this absolutely fascinating plant. It had been used by Pierre Tuberie even in fibrosis. What do we call that? Retroperitoneal, and it is used in many autoimmune or allergic diseases, such as, we haven't talked much about oligotherapy. Well, there are certainly interesting things to explore. Michel talked about copper. I use a lot of oligoelements in these cases, like copper in silver, and of course, working on the barriers. I'm not going back. And you see, I hadn't seen your slideshow, and I had noted the importance of the medical history because it is really essential to understand what is happening. So the third solution is the onset or awakening of an autoimmune disease. I'm checking if I can keep up. It's going to be tough. So sometimes, often related to a crypto infection, it means that we will have a true autoimmune disease or something that resembles it. It could be Guillain-Barré or it could be many other things. Obviously, in my opinion, we see it much more with the vaccine than with COVID, but we do see it with COVID as well, especially when there have been histories of autoimmune diseases. But for me, it is often because there is a resurgence of a crypto infection that an autoimmune disease awakens or manifests. In any case, we cannot do without a comprehensive immune assessment. Personally, we haven't discussed it, but I always add HLA typing, which provides me with a lot of information about immune weaknesses, the underlying conditions, predispositions, and also, as we will see a bit later, about predispositions to food intolerances. Well, you obviously need to have training and be accustomed to doing it, but I find that we underestimate the importance of HLA typing. We talked about serology, so I won't go back to that. We always perform tests for anti-nuclear antibodies and ENA to determine if there is indeed a specific autoimmune disease or not. Personally, I always add an immunological assessment to an immune disease to look for food intolerances, because I believe that there are, at least in 80% of cases, if not almost 100%. It is very rare for people with autoimmune diseases not to have immune intolerances. And there are certainly other assessments that could be done. I won't go into more details. Therefore, the management of the autoimmune condition, autoimmune disease, or autoimmune state with a somewhat atypical illness certainly involves microimmunotherapy, which is truly a good way to regulate We could add to this, of course, the management of barriers, as Dominique has shown, but we must, of course, have these concepts of barriers. Here, it's the ongenin that I already mentioned to you. Oh well, yes, I had included it. Sorry, I thought I had forgotten. For me, if there is an immune imbalance, and especially when there is autoimmunity, there is often a disruption of both the flora and the intestinal mucosa. Therefore, working on permeability and gut flora seems absolutely essential if we want to have a chance of regulating things in the medium term. Additionally, addressing immune intolerances appears equally essential. So, I have the chance to participate in an international research group on food intolerances, which allows me to see what is happening in many other countries, mainly European, but not only. We also have some colleagues outside of Europe, and it is extraordinary to see that we find exactly the same thing with very different medical practices at times, but we have exactly the same experience. We find exactly the same things. So, for me, the PRO-MENAT assessment is certainly the most rigorous, meaning it has the least risk of false positives or false negatives. It's not a perfect assessment. There is no perfect assessment. There's a word that I use all the time. I believe it was Natalie who mentioned it in her own way. We do not treat analyses, we treat people. This means, I also say, that biology informs clinical practice, and certainly not the other way around. There is nothing worse than dealing with biology without having clinical experience. It's nonsense. We make a lot of mistakes. What does that mean as well? It means that we can conduct an assessment on someone who has 0 symptoms. We might find some intolerances. They manage them well. This brings us back a bit to what Pascal was saying about the overall objective of our immune system. We are here to try to regulate ourselves. Having some IgG against certain foods is not necessarily pathological, so it is really useful if it creates pathology. So, there are bound to be some false positives and some false negatives in these assessments. Because, for example, if you frequently eat a certain food and have intestinal hyperpermeability, there is a risk that the food will test positive. This does not automatically mean that it is bothersome for you. That is what needs to be understood. Therefore, it is almost always contributory in autoimmune diseases. And sometimes, for example, in the case of ankylosing arthritis, it is miraculous. I have patients who are only balanced with food intolerances. I often complement it with HLA typing because one can have gluten intolerances. And despite a negative immunopro assessment for gluten, I am referring to people who are DR3, DR7, DQ2, DQ8. And when they are DR3, DR7, DQ2, I can tell you that they have a high risk of developing an autoimmune disease and a high risk of having food intolerances, especially to gluten. So the problem with dietary interventions is that gluten and dairy are not always the only culprits. One can always try to say, stop gluten, stop dairy. Maybe they are doing it for nothing. On the other hand, we overlook everything else. Well, obviously, these assessments have a flaw. This is the price not reimbursed. It's important to adapt to the patients and let them choose. We won't say he doesn't have much money. I won't deny him an assessment because he might want to have a more complete evaluation. He may want to know, and others will want to have smaller assessments. It is really necessary to adapt. There is a problem of false positives in food intolerance tests, which occurs when people have significant intestinal hyperpermeability, because there is what is called the CCD phenomenon. I made a mistake. It's CCD. CDD is something else. And in these cases, there are many vegetables and fruits that appear artificially. So it also requires a bit of experience to interpret the assessment in these situations. But above all, it means that it may not be advisable to conduct these assessments when people first arrive with a completely dysfunctional gut. Overall, it's simple to interpret, but it's better to have some experience and training for the more delicate cases. What you need to know is that, contrary to what is said, because these assessments are completely rejected by allergists, there are thousands of publications on these types of intolerances, meaning what we now officially call type 3 allergies, since this effectively measures type 3 allergies, which are now referred to as hypersensitivities. Non-celiac gluten sensitivity is fully recognized by official science, and yet allergists continue to tell us that it is useless, that these assessments are pointless. It works very, very well. So, in practice, just so you know, it's a simple blood test on an EDTA tube. It's quite easy. And for small assessments, they can be done with a drop of blood. This can also be interesting for people who are not doctors and cannot prescribe blood tests. When foods test positive, they should be eliminated for 1 or 2 months. And then, it is ultimately the patient who decides because the truth is in the clinic. If people eliminate a food and feel much better, I can tell you that they will continue, and when they feel bad, every time they reintroduce it, they understand after 2 or 3 times, they get it, and I stop this nonsense. It could be eggs, it could be almonds, it could be kiwis. So, it is really important to let the patient have their experience, but we need to encourage them to do so. There you go. And then we gradually reintroduce and rotate the foods. And it is important to avoid reintroducing the foods that tested positive on a daily basis. Sometimes reintroduction is impossible. We have intolerances to eggs and gluten that can last for years. In fact, patients have a lot of difficulty reintroducing. There you go. It's up to the patients to find their motivation. So, the other avenues, we haven't talked about them at all, and I won't go into detail, but there is low-dose naltrexone, or LDN, which is a really interesting option in autoimmune diseases. But it's a bit particular. I just wanted to mention it for you to think about. Melatonin is certainly interesting, but at what dose? It is a great antioxidant. It is not just for jet lag. It may be necessary to take a higher dose of 10, 12, 15, or 20 milligrams. Sometimes we may need cortisone in these situations. We can try to take action. These are the works of Jean-Marc Sabatier on the angiotensin system, which is certainly impacted or involved in these mechanisms at those times. So this is what we have indeed worked on in homeopathy, thanks in part to Laurent Hervieux. People who are familiar will recognize these prescriptions. And in allopathy, we also have sartans. It is Jean-Marc who suggests them to us, but also the ACE inhibitors, possibly the singular, the antihistamines that we find there. I will come back to that. I will come back to that now. I think there is something we haven't talked about much, which is mast cell activation syndrome, or MCAS, which is probably much more common than we believe in long COVID, and which may even be a pack involved in acute COVID, which explains the effectiveness of antihistamines. So, to act on a SAMA, we don't have many options because we have either montelukast, antihistamines, or chromoglycate, which hardly anyone uses. Histamine-poor diets are a bit complicated. The low doses of natural substances and possibly the mentioned IRS are involved. However, we really have very few leads today. So, SAMA, I'm going to go a bit fast, but that's because I'm not going to detail all of this, otherwise it will take too much of my time. If I wanted to include it in the slideshow so that you realize that the SAMA is really everything we have already seen in other definitions in the other conferences on long COVID. So I really encourage you to take an interest in SAMA, and we will try to find complementary treatments. That being said, what we have already seen in the previous conferences are also leads. Well, of course, if you have an autoimmune disease, it is essential to address the causes, starting with the crypto-infections. So in the persistences or scars of an acute COVID symptom, there are also very many. It can be anosmia, pulmonary sequelae, nervous system disorders, mood disorders, cardiovascular issues with sometimes very troublesome lesions, and renal sequelae. It is also related to microthrombosis and various symptoms, such as dermatological symptoms, including eczema, etc. And of course, these persistent symptoms may also be related to a SAMA. So, the management of the sequelae will depend on which ones. Obviously, we can propose different assessments that you may have seen today, and some that I have mentioned. And of course, it can be very complicated by the side effects of the vaccines that add to it. These sequelae may be signs of viral persistence. So we return to what has already been said. And obviously, in all of this, there is no consensus, but numerous publications. And this is mainly what I'm going to show you. It is this study from May 17, 2023, on spike protein-related pathology, which is now also referred to as spikeopathy. In this publication, there are 342 PubMed references, which is quite solid, and it proposes 7 allopathic treatments and 37 natural remedies. And to save my time, I will just show you the 2 tables. These are the 7 medications that show, in this meta-analysis, a recognized effectiveness in the various published studies. Ivermectin, cortisone, aminosteroids, aspirin, LDN. You can see that it has been well studied. We in France use very little, but we might be wrong. Colchicine, well, I'm not a big fan, and metformin. So I just included a study that was published, an article that was published in Vidal, which says that metformin is good, but it comes too late. I should have highlighted the most important part in bold. Early treatment with metformin seems to significantly reduce the risk of developing long COVID, but this protection appears to be on par with that provided by a primary vaccination. I love, and this diminishes the practical implications of these results. So you see that, well, they just forgot to mention the potential side effects of metformin and the vaccine, for example, because when we say that, we should consider the benefit-risk balance, and that will be my second to last slide. You will have all of that in the slideshow, of course. What are the natural remedies that are mentioned? D, C, K2, very, very important. K2, in my opinion, NAC, glutathione, melatonin, quercetin. This is an antioxidant. I have seen black seed, resveratrol, and turmeric, and all of this has been published. Magnesium, zinc, nattokinase, omega-3s, lutein, millepertuis, and fisetin, which is a very interesting antioxidant. The laboratory here offers these. Boswellia, also known as pigum, nutmeg, sage, rutin, limonene, and algae. The extracts of taraxacum, dandelion, the cinnamon that Claire mentioned, milk thistle, and andrographis that Claire also talked about. Take Bulgaria. I have no experience at all. Licorice, cardamom, clove, ginger, garlic, thyme, propolis. You see that all of this has been published in one way or another in spikopathy. So obviously our real problem is, what do we give? Because we could leave with a suitcase full of medications like this. This is where today we don't have enough hindsight and everyone is kind of experimenting. Some prefer to practice isotherapy and lift barriers. Others will provide more phyto and aromas. Some will prescribe antibiotics, and we will try to support this as best as possible depending on the patient, as Michel also demonstrated, with a number of therapeutic nutrients here. So, in the slideshow, you will have the different options for pulmonary management, but I've already talked too much, so I will provide it to you. And here I mention oral oil, which I personally really like, but which is not always very well tolerated. However, oral oil is absolutely great for the lungs. For the vascular system, of course, we have again some things we have seen. Omega-3, resveratrol, vitamin K2, which is very important in homeopathy, cardine, and especially all the venoms, with a particular venom from the scorpion, androctonus, as well as more well-known substances like these chalaise and the dogwood in gemotherapy, which is also very interesting. Willow and meadow arnica in phytotherapy, which can be an equivalent to aspirin, obviously, and a number of very useful plants for microcirculation. And vascular enzyme therapy. Obviously, this is not exhaustive at all. These are the main avenues that I tried to present to you in the neuro context. We will find omega-3s, B vitamins, and ginkgo. I am very interested in B3 at the moment and in the nucleotide, nicotinamide mononucleotide. No, NMN. We'll talk about it again. Yes, that's right. The ginkgo that should not be forgotten here. And in cardiovascular health, the antioxidants, the neuromediators that we haven't discussed much or only indirectly. But in my opinion, the plants that act on the neuromediator are absolutely essential. Of course, homeopaths, homeopathy, especially for neuropathies like calmia, hypericum, etc. For anosmia, honestly, I don't have many great things to suggest. In any case, it is important to treat, to try to address the causes. Maybe it's isotherapy. I'm not saying maybe. It's perhaps with the isotherapy of the virus that I had the best results, but it's very random. And there is also a part of healing that is spontaneous. Enzyme therapy is certainly important. Rehabilitation and some homeopathic remedies I mentioned, which have anosmia in their pathogenesis. But after all, it's not very, very accurate. And here it is the ongenin that can play for its effect, its dual immune and fibrotic effect. Yes, I know, that's why I'm hurrying. So, there you are. You use a lot of ashwagandha. I really like rhodiola, but both are important for the therapists in the room. I definitely haven't forgotten all of that. And I also mentioned an immune remedy that hasn't been talked about much, which is the second senior that can be really interesting. Here, we had seen Mireille, NADH, and then there's the nutritherapy that we have already discussed. I have provided you with the FLCCC protocol so that you have it. You will see that overall it is quite similar since they also address summer extensively. Well, they try. Only fluvoxamine is reappearing. There are interesting studies on this. I must admit that I don't use it. And I wanted to have a before and after post because I needed to pay tribute to Claire. Indeed, fasting is one of the therapies to consider for long COVID. Intermittent fasting, or long fasting in quotes, of 7 days, rather obviously, in a center certified by the Federation of Fasting Hikes. There you go. Thank you very much, and sorry for being a bit long.